Thank you, and good afternoon. So what I'll do, we'll be going through the all guidelines, as Professor Volterani said, will take forever. And I will just give you some snapshots on what is new in the guidelines. We know that the ESC classifies the level of evidence as class 1 as recommended, class 2 as should or may be considered. I mean, whether that is, there is a clear process in determining the class 1 and the level of evidence. That is debatable because it's, sometimes they take data from multiple randomized clinical trials and meta-analysis or meta-analysis. Sometimes they take meta-analysis. Other times, like for the chronic coronary syndromes, for example, they don't take the meta-analysis. So let's say, although there is a process that is in place, that is, there is some level of discretion to be used. Now, what is important for the peripheral arterial disease, these are the guidelines that have been developed together with the surgeons. And I think it's important for cardiologists to increase the management of patients with peripheral arterial disease, to start diagnosing patients with arterial disease in order to get from the radiologists or from the so-called vascular specialists, a lot of patients should be managed medically. And so the first recommendation, class 1, is that when managing patients with peripheral arterial disease, is recommended to adopt a comprehensive approach that will assess the overall circulation. So that means that you need to give graded importance to the coronary artery disease. So whenever you detect any peripheral arterial disease, you always have to look at the presence of coronary artery disease, especially if that patient is limited in exercise capacity and therefore cannot reach the angina threshold. Then there is a suggestion to use applications and scoring system, as we've seen for arterial hypertension, but there is a focus on medical therapy and lipid-lowering therapy, with a target of an LDL below 55 milligrams per deciliter, and using statins, the same approach from chronic coronary syndrome. Statins plus ezetimibe. If statin and ezetimibe do not work, then PCSK9 inhibitor. Then if the combination of a statin plus ezetimibe is not achieved, they also open the door with a level 1B to bempedoic acid. We know the data, and we will hear data specific for the bempedoic acid later in this meeting. So what is important and what is the main message? Treat patients with peripheral arterial disease whenever you detect them, as patients are very, very high risk. So if you have patients with angina, if you have patients with other forms of arterial disease, and then you detect a plaque, albeit not significant, either on the carotid or peripheral, then be very aggressive. Then in patients with peripheral arterial disease, there is a clear recommendation for exercise. Exercise is the best treatment for peripheral arterial disease, especially for lower limb arterial disease, and is recommended strongly as a medical therapy. And then there are a lot of recommendations on the type of exercise. The type of exercise should be at least 3 times per week. Patients should reach at least their ischemic threshold and repeat the exercise. And when they perform high intensity, then see what is the threshold. So say when is the calf pain that occurs, and use that time as a time to assess the benefit of exercise. So as I said, training should be at least 3 times a week with sessions of at least 30 minutes and programs of at least 12 weeks. And Professor Volterani is an expert on this area and of exercise training, as has developed most of the guidelines for training programs. Then if we go for treatment, apart from lipid-lowering therapy, there's a need of antiplatelet and antithrombotic treatment. So if there's evidence of peripheral arterial disease, the treatment with rivaroxaban and aspirin, as we know, is recommended in these patients. Now, regarding the interventional treatment, in patients with symptomatic peripheral arterial disease, we need to consider the possibility of intervention, medical intervention, especially surgical interventions, after 3 months of optimized medical therapy. So if you have a patient with claudication, even if it's almost severe, then first of all, you need to implement medical therapy, exercise, and then afterwards send to surgeons. And in patients with the femoral-popliteal lesions, if they are detected, the drug-eluted stents should be considered as a first option rather than aortic iliac surgery. That is important because that changes a little bit the approach that is taken often in these patients where the surgeon wants to jump and do the intervention. Regarding patients with follow-up, there is a follow-up that is at least once a year, and it is important to recognize patients very early with critical limb ischemia. Patients with critical limb ischemia tend to have a 30% mortality at 1 year. So it's very important to identify these patients and see whether palliative care can be used. Now, there is a question on how we assess the carotid arteries, and we know that we have the NASCET and the ESCT methods. They differ in the way we measure the stenosis, whether we measure the stenosis and the proximal or the stenosis and the distal. It is recommended by the guidelines to use the NASCET method rather than the ESCT. And in all patients with peripheral arterial disease, there is a recommendation to use bilateral measurement and echo vascular ultrasound is the first line type of diagnostic test that should be taken in all patients where there is a suspicion. Now, regarding very specific questions, and I'll be very quick because I'm conscious of time, there is in patients with low or intermediate operating risk with an aortic arch dilatation or aneurysm, and an episode of chest pain that is not attributable to non-aortic causes, there is a clear recommendation for the arch replacement because that pain can be associated to arch rupture. Regarding the type B dissections, there is a clear indication for surgery in patients with a descending aorta greater than 6 centimeter, or in patients with descending aortic aorta of more than 55 millimeter. It should be assessed according to degree of risk. So there is a gray zone, and that gray zone has moved from 40 to 50 and now to 50 to 60. So we tend to be more open in terms of type of management. Now, the last two topics are patients with specific conditions, genetic conditions, patients with Ehlers-Danlos. I don't know how many you see here in the Emirates, but they are very, very frequent where I practice in the UK. And there is a recommendation for regular follow-up in these patients for their aortic aneurysm. And regarding patients with Marfan, then in Marfan there is a stage recommendation of echo measurements in patients with an aortic root diameter according to the dimension. If it's less than 45, in less than with absence of risk factors, then there is at least every 6 months, every 12 months, every 6 months in those with additional risk factors and diameters less than 45, and in those with more than 45, and echo every 6 months. And for treatment, Basically, we need to keep the blood pressure low. I don't think that there is any difference between ACE inhibitors, ARBs, or beta blockers, but the indication is mostly to lower blood pressure. And I stop here. I think I finished just on time. Thank you.